Good evening. My name is Braden. I use he, him pronouns, and I want to thank you very much for taking time out of your likely busy day to conduct this interview. Now, the prompt that I've been presented with discusses how patients with many rare, also called orphan diseases, don't have FDA-approved treatments for their conditions. However, when drugs are made for them, they're often very expensive and sometimes inaccessible. And in light of that, it's asking if I think that drug patents should last for a few years so that cheaper generic versions can then be made for availability. Now, before I give my personal perspective on the matter, I want to quickly outline the way that I'm going to explore a situation like this one. And to begin, I want to begin by acknowledging the complexity of the situation and the responsibility that change makers have, talk about some of the pros and cons and the ways that people might describe the way they lean, talk about my decision in this case, and then move that towards how it might relate to my future practice as a physician. So let's circle back to the beginning here. First, I want to acknowledge that creating policies in areas like this are extremely complex, and that's because there are many stakeholders involved. And these stakeholders go far beyond just the patients who are, afflicted by this rare disease. It's going to include pharmaceutical reps, pharmaceutical company C-suites, also physicians and PAs and anyone who can prescribe. And it's also going to impact people who own factories and manage drug transport and infrastructure, as there's going to be varying levels of distribution and cost for all of those parts of the chain, which therefore will be altered if there is a change in the policy. And because of that, it's my belief that any change maker in this area has a responsibility to extract the maximum amount of benefit out of that change to ensure that we live in a society that values its people and inhabitants, especially in this medical context. Now, let's move into the second pillar of my response, which discusses the pros and cons. And I'll begin by describing the ways that people who see the pros of this, meaning that they should allow patents to be dissolved after a few years for greater accessibility. And I think the overarching point that would be really brought up here is about access. Here in Canada, the Charter of Rights describes how people have a right to obviously universal health care, but care that's accessible as well. And really having this access to these drugs and also these possibly life-saving treatments, it really is a cornerstone to our medical profession as a whole. And it also further bolsters trust in the medical system if we have these things as well. It really creates that sense of security and safety for all people, regardless of disease diagnosis or condition, to know that there are legal and procedural safeguards in place to ensure that people have access to the care they need. And this also takes on a very personable and emotional side too. I couldn't possibly imagine what it would be like to, be one of these patients and come to the hospital and really have a physician say, "We can't help you because either this drug is unaffordable or it simply doesn't exist." And that would be a major, major sticking point for people who talk about access as a pro. And moving forward from that into the con section. And I think the main part that would be really discussed here is just the cost to the drug companies themselves. Discussing the expensive portions of the way drugs are developed really calls research into play. And it is a truth in the pharmaceutical industry that the time for research, development, and execution of clinical trials is both lengthy and very, very expensive. So if we were to, have these patents then fall away, the drug companies lose that revenue to actually do development for these life-saving treatments in the very first place, which can also mean that the treatment will just end up dissolving because there's no resources, for them to be made in the first place. And I think another less touched upon point is that of reproducibility and replicability. In the prompt, it states that many of these diseases are very rare and hard to treat. Now, if the patent for the drug company that did all of this research and development just disappears and there's now generic access, how do we know that the new companies that are taking this place have done that same rigorous testing and research and development to ensure that their new generic version is just as safe? Because of that, I think it's very important to keep in mind that level of safety as well for the people who would be seemingly accessing a safe treatment, but yet it may or may not be known. Now, with those portions in mind, being on the pro side, levels of access, and on the con side, cost and replicability, I want to talk about my perspective. And the way that I see this situation moving forward is kind of in a conjunctive middle ground. And what I mean by that is I don't think that drug patents should necessarily become fully open source, but rather have an open area of collaboration. I think that the original company could create programs where advisors and medical professionals, whether it be pharmacists or chemists or physicians, come into that company's fold and are then able to reproduce those patents for themselves rather than just creating a new generic version. And this has been an industry precedent, excuse me, for a very long time for times when disasters needed to be dealt with, whether it be American production in World War II or testing for AIDS during the 1980s or for COVID vaccine reproducibility between companies. So I think this is a precedent that has A, been used in the past, and B, can really be brought forward into the future. And making tough calls like this is going to be, something that's going to be it's going to be, excuse me, an important skill for me as I move forward in my time and practice as a future physician, especially if I choose to work in the realm of either pharmaceuticals or public health in supplement to a clinical practice. Because the decisions that I make and the perspectives that I take are really going to influence this chain of treatment and continuity of care in the future. So that is very much something to keep in mind. And with the approximately 2 minutes left, do you have any further questions on the way I think drug patents should be handled for accessibility's sake?
Yes, thank you. Beside the point that you mentioned and beside the pros and the cons that you mentioned, do you think there are any other alternatives to solve this problem?
That's an excellent question. And by the problem in question, are we talking about the disease itself, the social disease burden, or the drug patent problem of producibility?
The medical access to the to the medication, the
Okay,
access
that's
to new
excellent.
medications.
Excellent. Thank you for the clarification. I think another way to improve access to medication is to really take a systemic examination into the social determinants of health that influence people, especially in our province here in Nova Scotia. One can look to the way that these factors really intersect with access to care, whether it be not access, but access to housing, excuse me, whether it be dependence on other drugs, whether they be illicit or prescription. Talk about the SES gradient as well of whether people are able to afford their basic daily needs and whether they have access to clinicians and pharmacists or if there's even a clinic constructed in their neighborhood if that municipality is more rural. So I think really taking in that examination and then creating public health policies and practices that allow for access to really just be gained for people to get into the sphere of care in the first place, and then those solutions in which I've previously summarized, whether it be that conjunctive approach where large quantities of drugs are able to be made affordably while also keeping the company in business, can be executed and given to that broad base of patients who now have access, irregardless of their social standing and the determinants of health. So with these last 10 seconds, I want to thank you very much for the follow-up and for listening today, and I hope you have a wonderful rest of your interview cycle. Thanks so much.
Hello there. So my name is Dr. Aras, and how do you say your name?
It's pronounced Braden, and very nice to meet you, Dr. Arras.
Nice to meet you. Nice to meet you, Braden. So do you see the question in front of you on the screen?
Indeed, I do.
Excellent. You have 8 minutes to answer the question.
All right. Well, one, I'd like to say thank you very much for the introduction, and I hope you're having a wonderful interview day, and thank you for taking the time out of your schedule to conduct this. Now, the question I'm being presented with is stating that
Sorry,
I'm.
Braden. I can't
Oh,
hear
go
you very
ahead.
well.
Oh, no, that's all
Can
right.
you?
Let me just check my microphone here if you don't mind.
Yeah, now I can hear you. Now I can hear
Okay, most excellent. Thank you. So, circling back to the start of the question, it's presenting me with a scenario in which I'm in semester one of medical school and I'm taking an anatomy class where I got a 67, and that's unfortunately not a passing grade. And then we're wondering what steps that I would really take in that situation. Now, to begin, I want to just quickly summarize the way I would approach the situation. And the first involves pausing and self reflection. I'll expand on what that means in a moment. Then talk to my peers about what actually happened, and then move into seeking actionable supports, and then talk about how the culture of medical school and the way that those supports exist can also help me in my journey to success. So let's circle back to the start. I think the first majorly important point here is really taking that pause. And what do I mean by pause? It really means that despite the, likely obvious distress I'm going to find myself in, I really need to take a moment to self-regulate. And I'm going to do that by calling upon a technique that I've discovered from an article by Stephen Porges from 2009, and it's called polyvagal theory. And I've been using this technique in the past 5 years throughout my university career and also during my time as a wilderness EMT to help calm my nervous system. And what that involves is taking between 10 to 30 seconds and just, removing myself from that situation, whether, maybe it's the computer at home, I'm just going to go to the next room, maybe I'll jump outside. If I'm in a clinic, I'll just go outside the room, take those 10 deep breaths to calm down, and then re engage. And that allows for a calmer nervous system to really approach this more objectively and with better outcomes in mind. Now, with that calm demeanor now established, the next thing I want to move into is that self-reflection, because this is the really really big key for this. I need to take again that pause and really investigate what did I do here, and what factors, both internal and external, might be influencing the grade that I've received. Perhaps there's a personal crisis that I have going on outside my life of medical school, and I might have spent time, dealing with that or needing to help someone who's very dear and close to me. Perhaps there is something more related in the professional realm going on. Perhaps I've been in conflict with some other students in class, which has caused me not to attend. Perhaps I've had scheduling issues with clinics or different, parts of the curriculum, like skilled clinicianship or professional competencies. Or perhaps I was, possibly sick and just ended up missing some of the points, or just from my own error and a lapse in reading. Just really making sure I know what happened there is very, very important. So once I do that pause and that self-reflection, I then move into talking to my peers and classmates. I would see if that mark was representative for everybody. Perhaps everyone was scoring in those mid to late 60s of scores, or maybe I'm really an outlier and everybody else got 95s, and I've been sort of left in that metaphorical dust. And that's something I really need to establish to know if there is that, possibly that deficit, which is always improvable, of course, but how am I comparing, and where's my knowledge base? So with that in mind, if I seem to find that there really is a big issue with my own personal understanding, I'd move into seeking supports. And what that might look like is to seek a tutor who is very knowledgeable in the subject, whether it be someone who is in medical school or possibly in residency. I would talk to student affairs to see if their office can give me any pointers or directions in which to go. And that would be especially effective as well if I was able to be connected with some teachers or professors who really knew the ins and outs of that class. And especially if I could get to the teacher who administered and made the exam, we could really have that hopefully very productive one-on-one conversation where I could get honest, and maybe the feedback is going to hurt a little bit because it's going to be open and I wasn't able to perform to the standard in which I would have wanted to, but it's going to be valuable for my personal development regardless. And me reaching out to take those steps despite the possible uncomfortability is something that is very, very crucial, especially in medical school, to foster that learning. And I think another major point that should be touched on as well is that in medical school, at least from the outside looking in at this current point, and also looking through Dalhousie's culture and strategic plan, one of their main points is really that of valuing people, and you can see that in all of the policies that they make and the way the classes are conducted. And I think that's very important because I can go into the situation knowing that the culture has my back, despite the fact that I may not have performed super well on this exam in the first place. But that gives me the confidence to know I can reach out to those resources that I've listed, whether it be student affairs or teachers, or maybe even the anatomy TAs who are able to, show some goodness out of their own hearts and take some extra time to help me out. And just getting that comprehensive picture of, well, one, reflection, two, peer-based resources, three, professional resources, and four, really relying on that strong school culture is something that I'm very much going to lean on if I find myself in a situation like this where the grade wasn't passing. So with these last approximately 2 minutes here, do you have any further questions on what I would do if I received a unfortunately failing grade in this scenario?
Say you try again and again and you fail twice in a row, so this is three times in total. How would that change your approach?
Hmm. That's a very excellent question. So I think if I was failing multiple exams in a row, I would really need to obviously start at square one of my, amounts of self-reflection and really keep in mind what is actually going on and try my best to get to the root of those problems through examination and use of resources, excuse me, and also taking the courses of action that I previously relied on. However,
How do
if
you know that you are good enough to pass those exams? Medical school is hard and clerkship is hard. So how do you know that you are capable of achieving this?
That's a very excellent prompt. And the way that I really rely on my own self-efficacy to, find myself out of these hard situations relies on the basis of a positive mental attitude. And that's something I've managed to cultivate through really years of practice, both of that, those pausing and moments of self-reflection, but also through, research into different forms of media. But surprisingly enough, my journey in music actually cultivated that a lot, and I'm very much into a genre called positive hardcore music, and it's kind of metal adjacent. But the messages are those that are inherently positive and right about the ways that we can allow ourselves to learn and grow, and that despite our quest for perfection, sometimes we're still whole and complete human beings in spite of our failures. And that really actually inspired me to start a band on the matter as well, which I'm still currently playing and very passionately with this concurrent run to medical school. So, to answer how I would find that self efficacy is to call upon those system regulatory moments and also the knowledge that I am good enough and, get those support messages from people around me who have my back as well. So, combining those three facets, I think, is key. So, I want to thank you very much for those follow up prompts, and I hope you have a great rest of your interview cycle today. Good evening. It's very nice to meet you. My name is Braden. I use he, him pronouns, and I want to thank you very much for taking the time out of your day to conduct this interview. Now, the prompt I've been presented with states that I'm a medical student who stayed in the hospital late and I'm finishing patient notes. But I've overheard an attending saying that, quote, our patient is acting in a certain way because they are Black. And then it wants to know how I would approach this situation in the context presented. Now, before I delve into that, I want to quickly summarize the approaches that I would need to take and keep in mind to ensure this is resolved well. And to keep that in mind, I would start by enacting some immediate damage control if that patient actually overheard what happened, then move into gathering info while also taking in perspectives about Black history and the way that intersectional identities have really created and influenced treatment of different cultural groups in Western medicine as a whole, then move into actionable solutions while keeping power dynamics in mind about my place versus that attending physician's place inside the hospital, and then how these learnings are going to relate to my future career as a physician. So let's circle back to the start here. I want to begin by acknowledging the need for possible damage control. If this patient overheard what was being said, we would be in a lot of trouble, both as the individuals working in the hospital, but also as an institution, because comments that are disparaging in this way really work to undermine the limited trust that African, Nova Scotian, and Black populations can already have in our medical system. And this is not without good reason. If we examine the history of Black cultural development here in Nova Scotia, you can note the arrival of the Black Loyalists and the Jamaican Maroons in the 1790s to early 1810s, and then move that through the abolition of slavery into establishment of places like Africville here on the Halifax Harbor in the 60s. Now, it's important to note the blatant systemic racism that took place in these areas as well, with the last houses being frankly bulldozed by our city in about 1970 and having the residents just simply relocated without their consent as well. And really exploring that actually led me on a journey to talk with a really nice guy named Rakeem at the Black Cultural Center here up in Dartmouth. If you are going that way and turn right before Lawrencetown Road, you'll know the building I'm talking about. But he really gave me a valuable perspective about why African Canadians can end up mistrusting our medical system. And he cited things like the Tuskegee experiment, where syphilis was given to and not treated in Black Americans in the 30s throughout the 60s, and how there was no informed consent in that, and also the racist remarks that came from various physicians, and also the systemic discrimination through Africville as well here. So these perspectives that really create mistrust of different cultures in our medical system is not unfounded, unfortunately, because I can't imagine what it would be like to have this systemic items perpetrated against me simply because of the color of my skin. And because of that, it is our real duty as physicians and health practitioners to ensure that we continue to build trust in the system. So with that in mind, if the patient did overhear, circling back to that, I would really need to do some damage control. And what I would do to do that is call upon something I refer to as the art of being with. And this stems from an article I read by Stephen Porges in 2009, which relates to something called polyvagal theory. And what this allows us to do is when we regulate our sympathetic nervous system by lowering our heart rate and breathing to be calm, and combining that with compassionate language, open body language, and warm facial tones, we are able to attune to people's energy and show them that they are safe despite the situation at hand. And we need to also combine that with telling people, hey, like, I know that this just happened, but I promise that even if you don't see it them, is that I and other practitioners in this hospital are on your team. And we're here to make sure that you have a safe and a productive experience here in the hospital as possible. Now, with that in mind and that damage control done, I need to gather some more information on why the situation arose in the first place. I need to investigate, likely not by direct means because of the power structure here present in the dynamic, the attendings' opinions and the way that they interact with multicultural populaces to begin with. I might do this by talking to some peers that are on my level as to not violate bounds of professionalism by talking to people down the rungs, but also not taking that risk of retaliation by going up the rungs. Along with that, if the comments that went along with this are disparaging enough, I would likely involve some anonymous reporting through possibly student affairs or postgraduate medical education forums to ensure that we are creating a hospital environment that is right and just for all the patients in which it's involved. Now, with that in mind, that's likely the way that I would really approach the physician's perspective in this case is after gaining that breadth of why this actually happened to begin with, and also examining what the patient's behavior was and recognizing the various facets it might come from, whether it comes from either fear of the healthcare system in general or the way that they've been treated by this attending physician who clearly has biased views. That's something we need to keep in mind as well as we move through this and talk about realms of realms of disciplinary action. And to relate to those disciplinary actions, I think the best course here would be to create trainings and experiences in cultural competence. And the way that we can do that is through courses and some mandated education, along with possibly having supervised volunteer hours for underserved populations, which can be executed by the will of the Royal College of Nova Scotian Physicians and Surgeons if we need to undertake that disciplinary action as well. And because of that, I think we'd be able to really try my best to make a more broad, multifaceted, and safe hospital culture, despite the assumptions that can be made here, and also despite the existing biases that exist, and calling that into the importance of the way that Black and African Nova Scotians have been treated. So just bringing that all together, I think, is really the way that I would move forward, and also doing it in a way that ensures my safety as someone who's operating within the hospital hierarchy. So, with that in mind, do you have any further questions about what I would do if some disparaging remarks came up based on race in the future?
Yes. So after speaking with the doctor, it turns out that they actually was speaking to the nurse about sickle cell anemia, and they were actually referring to a medical condition and nothing to attack the person because of their ethnicity. So how do you approach the situation?
That is an excellent question. I think the way that the STEM presents this phrase, it is very easily open to types of misinterpretation, and some of the speech in here may obviously come off as insensitive, as the effects of sickle cell anemia really do relate to pain, which is a universal human expression. So the fact that the attending was able to relate that directly to race doesn't necessarily make sense from my perspective, but I think also gathering that
I'm
full picture
sorry, I
would.
should have clarified. Sickle cell anemia is predominantly present in the African community and the Black community.
Yes. Okay, thank you for that follow up. But also, some exacerbations of sickle cell anemia do relate to an amplified pain response, which can often be treated with opiates. And my perspective was simply stating that pain is an overall human condition. And while I do understand that anemia is seen along racial gradients, that's also a possibility. And we could say that maybe the patient was in pain because of the sickle cell, which is predominantly occurring in Black populations. So thank you for the follow up, and have a great rest of your day. Good evening. It's very nice to meet you. Excuse me. Oh, okay. Sorry about that. My name is Braden. I use he, him pronouns, and I want to thank you for taking the time out of your day to conduct this interview. Now, the prompt
Nice
that
to
I've
meet you,
been
Brayton. My name is Dr. Ras, and I look forward to hearing your answer.
Thank you very much, Dr. Arras. And once again, it's very nice to meet you. So, the question that I've been presented with here is discussing how baby boomers are getting older as a generation, and the number of senior citizens in Canada is going up. And it's asking how we can improve healthcare for this sector of the population. So, to delve into that a little bit deeper, I want to summarize the way that I would explore working on an issue such as this one. And I begin by acknowledging the complexity and responsibility of policy changes in this area, move into talking about a bit of a personal stake I have in this as my parents are, getting towards the senior side and the importance of that care to really ensure that the people I love are living a strong quality of life. Talk about some directly implementable, actionable solutions, and then move in to discuss how this relates to my future practice here in Nova Scotia, along with some initiatives that Dalhousie specifically is taking on. So let's move back to the start. Talking about the way we can improve healthcare for aging citizens is a very complex issue, as it goes beyond just people who are aging into senior citizenship. It's going to influence people all across the chain of continuity of care, whether it be nurses or health aides, transporters, people who are building infrastructure that's accessible, physicians, obviously, of course, and then people who are well versed in health policy, and then those who are mapping out our population pyramid, so people involved in sociological studies and population graphing as well. And because of that, any policymaker here, in my belief, has a responsibility to ensure that new changes really extract benefit to ensure that everyone in our society is living well. And especially to call that to a personal point, like I mentioned previously, my parents are getting a little bit older. They're beginning to near their 60s. So the time in which they become senior citizens is soon going to be upon me. And the changes made in policies here are going to directly affect, obviously their quality of life. And those are people I love very much. And I'm also likely going to be caring for them as well. So having those really intertwined together to make a great experience for all of us is going to be really, really important. As like, of course, I can't. It would be very hard for me to imagine the emotional weight of not having these things in place and having to deal with that fallout. And it would be a very tough time for both me and them. So this is important to, my heart as well. And I think to really move into, making meaningful change, there has to be a cultural acceptance of seniority. And one way that Nova Scotia is really doing a great job at tackling this is through their shift plan, which is working to combat a culture of ageism that that can sometimes exist in our society at large right now. And I think that real key is showing that people of older age, especially as they go up in their 60s,
Sorry, what's the
hold.
name of the program that you mentioned?
Oh, sorry, it's called the Shift Program. SHIFT.
Okay, and it's in Dalhousie?
No, this is a Nova Scotia Health Initiative.
Nova Scotia. Okay, nice, nice.
Yeah, yeah. Thanks for the reference. Continuing on, I think it's very important that policies like this exist because it shows that and creates a culture where our senior citizens are very well valued for their knowledge and experience. And keeping that in mind creates space in our heart and motivation to create changes that help them to live well. And moving into that, I think the one important development is those of single floor living neighborhoods, as they very much allow for accessible living. So people don't have to, face that eventual challenge of getting up those stairs and are still able to live fully independently without cares of someone like a CNA or an LPN who would need to come into that living environment to provide care. And also, when it comes to transportation for maintaining that quality of life, Nova Scotia has a great service that's called Accessibus. And what it is you're able to call upon a public transport system to take you, whether you're living with a disability that may have come on from something that is or isn't related to old age, and make sure you can get around to your grocery stores or to your appointments or to whatever social events you choose to want to go to. And that also really delves into an important facet of elder loneliness. And making sure that we can combat that as well is a very, very crucial thing. Back in grade 8, interestingly enough, I was a musician, and I still am a musician. But I was part of a volunteer initiative that played jazz concerts at senior citizens' homes, and that really helped to give people something to look forward to during the day, and also have that social facilitation between young minds and the minds of seniors to share stories, ideas, and experiences to really create a better future for all of us. And especially as I move into a future practice as a physician, that those experiences and also the systemic portions of geriatric care are going to be very, very crucial to my understanding of the medical system in which I'm inhabiting, especially because 25% of Nova Scotia's population is going to be over 65 by 2030, which ironically is the year I'm going to be graduating medical school if all goes well this interview. So having that understanding is going to be, very, very important. And that also with some research that Dow is doing with their geriatric clinic, and really they're really pushing that needle forward in ways to really delve into and diagnose signs of early onset dementia, and especially that with Korsakoff syndrome, which is one of the only dementia types that is reversible through addition of vitamin B1 to the diet. So if we're able to, expand those initiatives, and also there'd be something I'd be interested
Sorry to
in
interrupt you,
possibly joining.
Braden, but I just have a quick point to say here. So even with all the
100%.
positive things you are mentioning, in my opinion, I still think that that Nova Scotia and the Canadian Society abandoned their elderly. And if you go to any care home, if you went to any of them, you find that the quality of life there is miserable. And I don't know if you would be okay with your parents going there. I would not. So what would you say about this?
That's actually a very excellent point to bring up, and I think some of the things that have happened in Halifax with the Northwood retirement home during COVID do certainly speak to that perspective. And I think that also calls upon the way that nursing staff are treated in the healthcare system in which we. And if we're able to, sort of break those issues of understaffing and underpaying and undervaluing those really crucial people who are working in healthcare, along with fostering those cultural changes and systemic changes that allow for better quality of life, I think those, deeply emotional and heavy problems that you talked about can help work to be alleviated. But it really takes us as a village, whether we're young or old, in or out of healthcare, to make those things happen. But I really do appreciate you bringing that up because that's obviously a vulnerable thing to really discuss, especially if you have personal experience in the realm. So I think that's extraordinarily, valuable to as a perspective to bring up. But in summary, to combine the facets I've talked about, whether they're personal, systemic, or relating to staffing issues and culture within those retirement homes in general, I think is the way that we can really push that needle forward in all facets of the healthcare system to make a better world for all of us and our senior citizens as well. So, in these last 20 seconds, I want to thank you very much for taking the time to listen to my response, bringing up that follow up, and I hope you have a wonderful rest of your day and interview cycle. So, thank you so much for that. Much appreciated.
Thank you, Braden. Have a good day.
All right, good evening. It's very nice to meet you. My name is Braden. I use he, him pronouns, and I want to thank you for taking the time out of your day to conduct this interview. Now, the question I've been presented with is asking me to discuss a time with you about when an unexpected problem really derailed some planning in my life at some point, and how did I recover from that? And to really delve into a story that displays that, I would like to call upon a personal experience I had while preparing for the MCAT, while also concurrently learning to be a wilderness EMT for the Canadian Ski Patrol. Talk about the self reflection and radical changes I made to my approach to overcome that problem. And then talk about how I took those lessons into being able to manage a problem that came up with a research project I was working on with the Canadian Ski Patrol very recently, and then how these learnings from that also relate to my future career as a physician. So let's circle back to the start and we can begin with that. Our story really takes us about a year and a half ago. And at that point, I was very much right in the weeds of studying for the MCAT and really trying to conglomerate all the learnings that I gained from my first 3 years of my undergraduate degree and execute them into creating the best possible outcome for my score as I could to make sure that I could work towards and get into this dream of making it to medical school. And while doing that, I was also working to really expand my scope of medicine that I was able to practice as someone, still in the undergraduate phase by becoming a wilderness EMT for the ski patrol. And I was working on both of those things at once. Now, despite all of my preparations and feeling that I really had everything dialed in order for my MCAT prep and my ski course, when I ended up taking one of the full-length diagnostic exams for the MCAT, the grade that I got back really didn't feel satisfactory to me. In fact, so much that it made me consider whether I would be able to actually write the test on that date to begin with at all. And that was a deeply emotional moment for me because those few months of prep that led up to that seemed to have just fallen away in that moment, and that was something that held an emotional weight really on me. But I knew that I had it within my heart and motivation to make that recovery from this unexpected issue. And to begin, before I moved into that, I started with some time of radical self-reflection. And what I mean by that is really just taking a pause despite the chaos of the situation around me and really regulating my nervous system down to lower my heart rate, lower my breathing, make sure we don't get to that panic state, and instead have a calm demeanor in which I can really focus on some self-compassion to know that I'm still worthy of this journey and able to continue in it, but also to make some actionable solutions to ensure that I can succeed. And that really that first step really came into play with just the pause. And then moving forward from that, I then began to sort of reevaluate my research into the way that I was studying for the MCAT and made sure the methods I was actually using were right and effective based on what has been done before, which I think is very important. And then along with that, I began doing some resourcing. I reached out to some tutors and I reached out for to some friends of mine who are a little bit further along in that in this journey of taking the MCAT and applying to school, and really tried to get as much advice out of them as I guess out of them makes it sound a bit like I'm just fishing. But we had generative conversations to really ensure that I was able to set myself on a good track moving forward. And along with that, I think a real key is just relying on good old fashioned effort as well, along with all of these facets, and really just ramping up that study schedule and really walking that path of studying and just living in those moments of being interested in the topic material and all the things that come with it. And by implementing that, I was able to balance both the ski roles and the MCAT role. Sometimes I would study in the tool shed at the hill if I had to, calling back to that good old fashioned effort. But I was able to get my score up to the area that I wanted and then move forward with this application process. So I'm very happy to be here today because of that. Now, the lessons that I took forward from that ended up really helping me in a recent project I've been working on with an emergency medicine physician here at Dal. And we both have an interest in a medication called Penthrox and how that relates to usage in a ski patrol environment. And just to quickly summarize, Penthrox is an inhaled pain medication that is similar in effectiveness to something like morphine, but it's not an opiate, so it lacks that Schedule 1 classification. Now, because of this sort of gray area of what the medication is in its public perception, our mountain safety director saw our plans, but had a really grave concern over security and whether people from the local area would, try and get at the storage compartments and steal it, or try and resell it for any number of any number of, excuse me, any number of approaches they could use. And I think that came from, as he stated, his experiences being an ex-police officer and witnessing the culture around the municipality that the ski hill is in. But I was able to call back upon that pause and then talking to other resources, whether that be other ski patrollers in that case, or some of the mountain safety director's colleagues, and also reading into peer-reviewed research to find out that if we were able to bring the Penthrox on and off site on the same day, those security concerns really were no longer a concern because we could keep tabs on the location and usage of the drug. And that allowed our plan to get right back on track. And I actually have a presentation to the broader Ski Patrol Committee about this tomorrow. And I'm very excited to, display to them that we're going to be able to move this forward and create success for everybody, and also better and safer patient outcomes for those who unfortunately find themselves in a crash on the hill. So I think that's a very important way I was able to harness these lessons and then push them forward into the future to create better outcomes for both me and my journey, but also for other people at large. And I think that's a really core tenet of what physicianship really is taking lessons that you've ingrained from your past and bringing them into your clinical scope, and using those efforts and ability to pause and also to research to just create good clinical outcomes, and also a clinic that is safe and well for all the people who interact with it. And with that in mind, do you have any further questions about how I encounter and tackle unexpected problems here?
Why you want to pursue medicine?
That's an excellent question. And in the very short time we have left, in my experience in the medical field, I found that medicine is the only profession that has this beautiful intersection of personal connection, ability to lead, and also the ability to enact systemic change. And those are, facets that you can find in other professions, but I found only really one at a time. For personal connection, in the medical field, I'm summarizing very quickly, but one can become a nurse and have like some clinical scope that may or may not have all the autonomy and knowledge that I want to, exact, but we have that personal connection. If I want systemic change, I can pursue a master's of public health, but maybe that doesn't necessarily have clinical work. And if I want to be a leader, I can work in things that might be related to wilderness rescue or things of that nature. But then that sort of science background and ability to make meaningful changes in systems may or may not be present. So just to very quickly summarize, it's those three facets that make medicine the ideal and purposeful profession that I believe I want to pursue. And I'm very excited to have the opportunity to do so. So thank you very much for your follow-up question. And I hope you have a wonderful rest of your day and interview cycle. Thanks so much. All right, good evening. It's very nice to meet you. My name is Braden. I use he, him pronouns, and I want to thank you for taking the time out of your day to conduct this interview. Now, the question I'm being presented with is discussing how I am a medical resident working on shift, and that on my lunch break, I overhear some nurses talking about my co resident saying they don't have good communication skills, and then what I do to approach a situation such as this one. Now, before I really delve a bit deeper into that answer, I want to quickly summarize the approach I would take in a scenario like this one. And I think it would really center around first doing some damage control if that co-resident either heard or was offended by that, then really go into an important session of information gathering to know what's actually going on while keeping the hierarchy and power structures of hospital staffing in mind, and then moving into some direct solutions after that and how those solutions might relate to my time as a future physician who's practicing in a multi-dimensional team. So moving back to the start, the first thing that I would undertake is some damage control if the co-resident happened to overhear and we're feeling, very upset about that. Of course, hearing, disparaging comments about your communication skills may not sit very well with some people. So it would be important for me to be able to comfort them in that moment with empathy and compassion and really just, be with them and ensure that I can do my best to comfort them, but also hold the situation in mind when developing actionable feedback. So with that in mind, I'll move to what would happen if the resident didn't happen to overhear. And in that case, the first thing I would do is really gain a really full scope of why these comments are actually being said. That's something I very much need to know, and I need to get the specifics around that. Do these nurses decide that it's just this resident that have poor communication skills, or is it a complaint about multiple doctors either on the floor or within the whole hospital? And next, I need to know, what does communication skills actually mean in this context, and what's being communicated about. I think there's a very stark difference in situational approaches here. If the communication is about medicine requisitions or patient status or discharges, versus if someone just has a bit of an awkward conversation about the outcome of the football game that happened on Sunday. There's a very different level of professional delineation that might need to be noted about that. And moving into that too is if it is on that more, I mean, this is important for both the casual and non-casual side of conversation, but it's important to see if the resident has any, possible underlying, you know, underlying conditions that might affect their social skills. Perhaps they may have autism or Asperger's. And if they do, it's very important that this person isn't being discriminated against because of the way that they simply interact differently with people. Although it can sometimes be easy to form preconceived judgments or ideas about people if they seem different from us. But that's something we really need to work against and avoid as people in healthcare, because part of our job is caring for all types of people, regardless of social background or condition or anything of that sort. So with those things in mind, I would want to really begin by possibly talking with the nurses directly if they seem that they would be open to that based on my interpretation, or go through a different channel that maybe involves anonymous reporting as to not have display that professional dynamic of me disparaging nurses, because there is that power structure that exists between staff and the hospital. And with that, I would, if I talk to them directly, I would call upon something I call the art of being with. And that really involves me just coming to a situation in a very calm manner and using open body language and warm facial tones, along with compassionate language that says, hey, I can absolutely understand your perspective, but I really want to ask you what's underneath this and why did it develop? And we can hopefully have those generative conversations about what really happened and the ways that we can work forward. And perhaps with that conversation, the situation might resolve. But if I'm getting that sort of resistance, then I may need to go to one of those anonymous reporting options, or B, call upon different resources. And I think the things that I would call upon to, if it was a case of discrimination, would be those types of, educations based around communication with people who, may have autism or Asperger's or something along that variety as well. But we can also circle back into a different, part of the situation and examine what the co-resident was actually doing as well. Perhaps they are, someone who shows up to clinic often with a very snarky attitude, or that maybe they're having trouble with their clinical skills and they're not filling in charts properly. Getting that full scope of information is also very important. And then if there is a possible deficit on the side of the resident who's one of my peers, I can go talk to them directly and also exercise that, once again, art of being with, to show them that I really am, despite the possible struggles that might be going on, I'm on their team and I'm here to help them. And perhaps I can, work in a buddy system if they're having trouble with some of the charting. If they're feeling overwhelmed from the medical experience, I can refer them to student affairs and postgraduate medical education resources to get the, possible mental health support or maybe some time off if that's, available in the hospital's Rolodex schedule that they need to, really sort of overcome these barriers as well. So just watching, in summary, the different approaches and relationships that exist, the hierarchies that are there, and also examining all the possible options that we could use to really make the hospital environment a better and healthier place for communication is really, really crucial. And that's going to be a very important skill that I'm going to have to harness as a physician in the future, as I'm going to be, coming up through these multifaceted and multidimensional teams who have many different types of stakeholders, whether they're nurses, CNAs, LPNs, PAs, physicians, who are all going to have different scopes of practice and styles of communication. And creating an environment where people can feel safe and open to come to me with either issues or good things, and just create that work environment where people really want to show up every day and do their best because they feel seen, heard, and understood is absolutely key. So, with the last little bit of time we have here, do you have any further questions about how I would navigate the situation with a co-resident?
Yeah. How do you think you can prevent this from happening in the future?
That is an excellent question. And I think that revolves back to my point of fostering, open and empathetic cultures within healthcare staffing. It goes without saying that healthcare can be a very stressful and emotionally heavy job. And especially with, shifts being sometimes upwards of 12 hours long for nurses, sometimes even 24 to 28 for medical students and doctors. We can sometimes, create environments where burnout is possible, and then the high stress and sometimes sad outcomes and lack of appreciation from patients can weigh on us, and that can create environments where rudeness and short temperedness can sometimes prevail. But being able to foster that communication and create that sort of esprit de corps or camaraderie that I think we all mostly really seek to have as people can really help move that needle forward into a healthcare culture that really values its workers and makes people want to band together to show up to do the good work and help people every day. So I think that's very, very crucial and critical to have as a perspective here. So in these last 20 seconds, I want to thank you very much for listening to my responses today and hope you have an absolutely wonderful rest of your interview cycle. Thanks so much again for taking the time and hope you have an excellent day.
Thank you. Take care, Brayden.
I will. Thanks again.